afternoon, everybody. Lunch and Learn. It is Wednesday, August 15, and we have Dr. Ron Swatzyna with us again, part 2 of his presentation. You are all muted, and you are all going to stay muted. About 10 minutes before the hour, Richard will begin to unmute you, and we'll let Ron know that we're unmuting people, and then you can begin to ask questions. But we're going to keep everybody muted during the majority of his presentation. So, Ron, thanks for coming back and for part 2, and it's all yours. We see your screen.
Okay. Good morning. Good afternoon, everybody. I really appreciate this opportunity to get this information out. Be it known that you guys are the first group to get this information. So. I would like to have feedback afterwards and let me know what you thought about it. Okay, let's get into it. I can get my computer to work here. There you go. We work in a world where psychiatrists and neurofeedback clinicians rarely talk. Psychiatrists, they kind of discount what we do, and they really don't want to hear what we have to say. And that was when I started doing qEEGs in 2005 here, my psychiatrist here was kind of the same way. Just do neurotherapy, don't worry about the findings. However, many of our most challenging cases have multiple diagnoses and are taking multiple medications. I did a study on this actually, and ethically though, I have come across several clinicians and that do qEEGs and EEGs, and some people that are very high up in our organization tell patients that they should stop their medications and just do neurofeedback, or they should change their medications. Or if you, as PhDs, as therapists, we cannot advise our patients to do anything about their medications. Please stay on the ethical side of this. Your common thing that you always tell patients when they say, well, should I follow psychiatrist instructions? But we can provide psychiatrists with a valuable data to assist with medication selection. And this is what we're going to talk about today. This presentation provides the foundational knowledge needed to build a relationship with your client psychiatrist. I think this is going to open this tremendously. What we're talking about is Pharmaco-EEG. Pharmaco-EEG, if you're familiar with that, is a scientific discipline that was born in the 60s. It was for the prediction of response to psychiatric drug treatment, among other things, but never really made it into clinical practice. In Clinical EEG and Neuroscience Journal in the April 2006 edition, Galareschi wrote an article about Pharmaco-EEG at a crossroads, and she and another author wrote it also about how we missed the opportunity for Pharmaco-EEG. And now realize that psychiatry and our mental health in general is about 200 years or 150 years behind medical health. By this I mean that we're still basing everything we do on symptoms, not identifying what symptoms are causing the problem. Just like if I 150 years ago went to a doctor and said, I'm getting fat, I'm going blind, and then my toes are tingling. He diagnosed me with obesity, blindness, and toe rot. And of course, that's not the diagnosis we know now, because we have physical tests, scientific tests we can run, and we know that's diabetes. So that's where we're trying to make this change right now, in conjunction with the National Institute of Mental Health, who wants to make that shift in psychiatry and psychology. So Pharmaco-EEG lost momentum due in part to declining interest in EEG methods. It's been discounted by neurologists, psychiatrists, I guess, for decades. And applications in the research and clinical practice. Stuppen and Emery in 1995 had, and I found their publication on it's a World Health Organization publication, and it talked about the drug effects on normal human qEEGs. So it went through every psychiatric medication, and it actually showed brain maps of how the drugs changed the brain maps, but it also had a physical description, whether it increased beta or decreased theta or whatever, it would tell this. Now, Jay Gunkelman and Jack Johnstone produced the EEG phenotype model, and I think it came out about 2005. And Roy John, love him to death, had the homeostatic EEG regulatory system in the 2006 journal also. And I'll show you that. You'll have a privy to seeing his actually EEG regulatory system. All right. Back to the foundation. Jonathan Walker, I know you guys may know Dr. Jonathan Walker. He processed the first data 2000 for me in 2005 through 2009. And that's when I started with Jay Gunkelman. And I started publishing in this area in 2014. And the last slide has a list of all the publications relating to what we're talking about today. About 14 of them, I believe. Okay, so in this article that Roy John wrote, he said the developmental, psychiatric, and neurological disorders produce and are caused by deviations from homeostasis. And I think that was just really profound. I have a little addition onto that. And I say in a known direction based upon their brain pattern. I had an opportunity during Hurricane I in 2005, I believe. No, 2008 or 9. We had no power for 10 days, but I had electricity in my apartment, and we set pattern brains. I found about 18 distinct pattern brains using qEEG analysis data. And we know that these patterns are specific, kind of like fingerprint to everybody. So Pharmaco-EEG is based upon the following foundation. I don't know why I put a question mark there. Different psychotropic medications produce and a distinctive profile of change in the qEEG. That was what Stuff and Emery were showing. Correction of the qEEG deviations results in normalization of the disorders. That's what I've been working on for years. And qEEG deviations help to identify appropriate medications and minimize undesirable effects. So I will have to throw one thing in there that we talked about in part 1. However, we know that if they have isolated epilepsy form discharges, that's a critical bit of information, and it won't show on the qEEG because it will be either artifacted out or averaged out. Additionally, the call of a study being that it's got some sort of organic issue going on, some encephalopathy, that can't be seen on an EEG. You just show a lot of excessive slow activity, but low voltage slow EEGs called by electroencephalographer will also keep medications from working and your neurofeedback working. But we're not going to go into that today. We're going strictly into the medications. Now here is Roy John's wonderful diagram of the brain, and I actually got an emailed Roy John and said, I love this beautiful drawing because I have an electronics background. I said, can I get a copy? He said, well, it really doesn't belong to me anymore. I said, well, I'd love to make a poster on my wall. He said, I can send you an electronic copy, but you can't post it or publish it. It belongs to the journal. I said, fine with me. So I got the electronic copy, and I have a poster of it in my office, and I refer to it quite often. And as you can see, this is really a complex way our brain is put together, from the exogenous input on the left over here to the endogenous readout here in the bottom. So exogenous being that we're going to put in the stimulation we get from outside our bodies, and then the rumination and everything else we have gets wrapped up here in the nucleus accumbens, amygdala, and the hippocampus. That's why they actually, when they get traumatized, will actually get wrapped up in this circle, this trauma down here, and the hippocampus will actually start atrophying. So just to put that out there for you, it's all based upon a regulatory system. Okay, medications versus neurofeedback. We don't want them to be countering each other, because psychiatric medications alter the ligand-gated ion channels, and neurofeedback alters the voltage-gated ion channels. So one, like, is a thermostat on your wall for the neurofeedback, and the other is the freon and the ligand-gated channels for the medication. And yes, you're right. If you push on one direction and you push the other direction, you're going to nullify it. So you're not going to get the results you want. It's hard to counter a medication that's taken daily when you see a person 2 to 4 times a week. Makes total logical sense. Medication classes we're talking about. I think that when we go to schools, we are not given that much data on medications and what the mechanisms of actions are and everything else. But these are the simple little rules we come up with here, based upon stuff in Emery's work and my work and John Stone, Jay Dunkelman. Stimulants and NRIs increase alpha speed because they increase the norepinephrine available, or they block the reuptake of norepinephrine. Norepinephrine is an excitatory neurochemistry. It's got the little plus signs on it. If you look back on this, the little plus like acetylcholine and glutamate and all that kind of stuff, those are the excitatory neurochemistry. The ones with the negative signs or no signs are the relaxatory. Okay, so SRIs now. They reduce anterior hypercoherent alpha. That's their target. It's actually a serotonin issue, so they act on serotonin in order to stop some of the incessant thinking and make them less rigid and everything, and it works very well on those, except in certain cases we'll talk about. SSRIs, SNRI combinations are the medications that, like Cymbalta or Prestige, that actually work on both and serotonin. We'll talk about how that reduces the anterior hypercoherent alpha and increases the alpha speed. Again, we're looking at a key lock system in order to match the medication to the actual brain. And if the medication is not matched, it's going to create problems. Antipsychotics, they slow alpha peak and range. Beta blockers reduce beta. Anxiolytics reduce anterior hypercoherent alpha without stimulation. This like your booster, we'll talk about that a little bit. And anticonvulsants reduce the spike in transients and stabilize the brain. Stimulants, amphetamines primarily increase norepinephrine and thus increase the range and the peak frequency of alpha. Adderall and Vyvanse are just examples. I'm not going to give all the types in the class, but I'll give you some of the ones that we mostly see out there. Methylphenidates now are the perfect medications because of, for a high theta beta ratio, because if you have frontal midline theta, it's going to reduce that by working with the dopamine system more so than the norepinephrine. It does work on norepinephrine, but mostly dopamine. And so it targets frontal midline theta, high theta beta ratio individuals. And so if you've got one that has a normal alpha speed, the faster alpha speed, definitely you want to consider a methylphenidate rather than an amphetamine, because an amphetamine is going to increase the alpha speed. If he's already fast, you're going to make him worse. So again, if you've got one or the other on one of your ADHD, and you do have an ADHD pattern of either slow alpha or high theta beta ratio, then you would want to at least have the medication that matches what the brain needs. Concerted Daytona, Metadate, Focalin, Ritalin, to name a few. Norepinephrine reuptake inhibitors primarily blocks the reuptake of norepinephrine. Strattera is a good example of that one. Now, NDRIs, norepinephrine and dopamine reuptake inhibitors, block the reuptake of norepinephrine and dopamine. These would be kind of like Wellbutrin and Dexedrine. Wellbutrin is actually very, very stimulating. They've got it classed as an SSRI, but they do that as an anticonvulsant. They have it classified as an antidepressant, but it's for those depressed people that are stuck in bed and can't get out of bed and they need some energy. That's a good medicine for these if they have the pattern that matches it. A central nervous system underarousal pattern, basically. Contraindicated when epileptic form discharges are present. There was an article out by, I did the replication study from 2011 that talked about 25% of the ADHD children had epileptic form discharges. Now, if you put an amphetamine or methylphenidate on a person who has epileptic form discharges, it's going to make them worse. And in that article, it ended up that they said we should actually get the brain stabilized anticonvulsants before addressing the ADHD pattern with either methylphenidate or amphetamine. And we find that works very well in our practice. We've been doing that since 2006, 7, 8. Also, it's contraindicated with fast alpha or beta spindles. Now, last session back in July, we talked about beta spindles. What the medications, the amphetamines, and the methylphenidates do besides messing with alpha and reducing beta? They increase beta. And so if you have beta spindles, you don't want to make them worse. It will actually light them up like a Christmas tree. Not a good plan. So we have to know what's there. Selective serotonin reuptake inhibitors reduces anterior hypercoherent alpha, and these are a list of just some of them, not all of them. They are slightly stimulating, be advised. So if you've got a fast alpha person, you may want to reconsider or have the doctor know that it's fast alpha, and it could be too stimulating, or that could account for some of the anxiety increase when you put in a medication that's supposed to address anxiety, and it actually makes them worse. They reduce anterior hypercoherent alpha. They also, serotonin narrows the range of affect, improving affect regulation. But SSRIs, I could go into a whole hour just on SSRIs, but I can't do that today. It's an interesting neurochemical. They do stabilize the root to a certain extent by making the lows not low, but then you do knock off your highs. Contraindicated when epileptic form discharges are present. There was a large study in England, several 100,000 people in this longitudinal study, and they found that, 9% of those put on SSRIs for the first time develop seizure disorder. They do drop seizure threshold. They do make this activity worse, okay? So if you get somebody that would just put an SSRI and they start getting worse, and you've done a qEEG on them and sent it off to have it evaluated, and they say isolated epileptic form discharges or seizure activity, or however, which way the person reads it, transient discharges, sharp and slow activity, spike and wave, that's probably what's going on. Contraindicated, according to the studies from Europe, Mark Tynarns was very supportive in helping getting me this data. When beta spindles are present, they do not like to work together. They make actually bad side effects when you put them on and you got beta spindles. So another thing you'd like to know about. Okay, what can I account for anterior hypercoherent alpha? Okay, this is a little bit more on it. We're going to talk about that. Effects of Prostatic and Cymbalta are the selective norepinephrine reuptake inhibitors, as well as the serotonin reuptake inhibitor. These are the examples of it. Effects of Prostatic and Cymbalta. They increase the availability of serotonin and norepinephrine. They work in cases where the anterior hypercoherent exists with slow alpha. You might as well get a twofer out of a medicine if you can, and use one medicine instead of two. So if you've got a person with slow alpha and anterior hypercoherent alpha, that's the first thing you probably want to talk to the psychiatrist about and say, sir, you know, there's probably a medicine that would really be matched to what we're finding in the data. And, you know, that's why I put my papers in there, because you kind of get some support for what we're saying. They're contraindicated when anterior hypercoherent alpha exists with fast alpha, because, again, we're going to speed it up too fast. Contraindicated when epileptic form discharges are present for the same reason. It's going to make them worse. Contraindicated with beta spindles are present. So these are the ones that we do want to know, that if you've got them on and a lot of people with anxiety, they are on an SSRI or an SNRI, and it will be countering what you're trying to do to be successful. Anxiolytics, there's a non-benzodiazepine group of anxiolytics, Buspar, Mempramine for some. They target the anterior hypercoherent alpha with fast alpha, because the way the mechanism of action will in Buspar and Mempramine will not increase the alpha speed, so you can get the bang for your buck without actually causing an issue. Now the problem is that Buspar, for the most, excuse me, get a sip of water. Buspar, by its nature, It takes about 3 weeks to 4 weeks to take effect. And, you know, if the person's having a lot of issues with anxiety, waiting 3 weeks to get a break is tough. People love the benzodiazepines on the other side. The most addicting medication that was never intended for long-term use is being used by a lot of people. And you habituate to these benzodiazepines so quickly that it'll make your head spin. I mean, you know, within a month, you're going to go from what the starting dose to doubling the dose to tripling the dose. It's just terrible. And then they get to a point that the doctors cannot give you a high enough dose because you're so habituated to it now that it causes a lot of problems, and people will go and start buying them on the street. So if you got anybody on benzos, oh my God, you can't tell them what to do, but you can give them information that they were never intended for long-term use. You're not telling them to quit the medicine. You just give them information that they were made when you have a family member die and you want to get some sleep, you got to get some sleep. They give you 10 pills and they send you out, not a recurring prescription. So these are the ones that also abuse, as you can see in my last point, can result in creating a beta spindle, a medication effect beta spindle from a tranquilizer, which these are classified, can be classified as tranquilizers. And I have found people who are Xanbar abusers that once they quit 6 months later, the beta spindles are still there and they're absolutely miserable. What this medication does is enhances GABA, and they're very addicting. Gabatrol is a little bit different medicine, but you can throw Gabatrol into that collection as well. It slows the EEG, but they should only be used for short term. We mentioned that. Contraindicated when the alpha range and peak are slow, because what's it going to do? It's going to slow them down even more. Antipsychotics, my favorite medication that I hate, because there's very, very few people that actually, I guess I've done with Jay Gunkelman pushing 2,000 cases right now, and out of all the 2,000 cases, only 2 times has he come back and said an antipsychotic would be the one matched to his brain. They're classified as major tranquilizers. They target excessive fast alpha and excessive beta. Contraindicated when epileptiform activity is present, because they really, more so than any other medications, these really lower seizure threshold. And they're made, as they say, to counter psychosis, but if they don't reduce the psychotic symptoms, you've got to start suspecting that, and they make symptoms worse, you've got to start suspecting that they've got epileptiform activity that's causing their psychosis. Because in psychosis, you can have a temporal lobe epilepsy, which actually the spikes will be hitting the insular cortex. And the insular cortex has been known, when it has triggered by spikes, to actually start attacking or actually start promoting visual hallucinations. So insular cortex is involved in a lot of these things. So if you've got one that's been put on an antipsychotic that is truly psychotic and it doesn't work, suspect that you got spikes, and we need to change to what? Anticonvulsant. All right, nice segue. Anticonvulsants target epileptiform activity. Anticonvulsants, traditionally, according to neurology, you don't use an anticonvulsant unless somebody has had 2 unprovoked seizures and classified as having seizure disorder or epileptic. And that's the standard. And sad part about that is, I think a lot of people have been under medicated in this area for a long time, and there's a process called epileptogenesis, where this activity actually grows over time and spreads and goes from one foci to multiple foci, and then it becomes a seizure disorder. 25%, that's a study I referenced in my last paper, 25% of all the children who have epileptiform discharges will convert to a seizure disorder sometime in their adolescence or young adulthood, because there is a spread. We've been treating these kids for about 10 to 12 years now, and have had none develop a seizure disorder. I'm getting to start gathering all my data, and I got to go to parents who went outside the practice of immediate treat to see if you know how we can present this and so we can publish this study on it. Excuse me. Trileptal speeds up alpha and peak and range, as well as stabilizing. So if you have a person with a slow alpha and they've got spikes, it would be a great medication to get a twofer out of. You might as well get two things accomplished. But if you've got a person with a fast alpha speed, Lamictal is the choice because it doesn't have any effect on the alpha speed. Now, Tegretol is similar to Trileptal, and now we get to the ones that are GABAergic. Depakote. Depakote is the only anticonvulsant recommended for children and adolescents, or children, I think it is. Depakote, by its nature, is very GABAergic. It slows the alpha peak and range. So if you've got somebody that's got an alpha peak at 12, 13, a range up to 14, which I see, it's not uncommon for me to see that. You need something GABAergic to slow this brain down. Depakote would be, I don't like Depakote side effects, but we have chosen Depakote because of its GABAergic properties. Topamax, which they have appropriately nicknamed Dopamax or Stupid Max, because it does the same thing. It slows the brain down. It inhibits glutamate. Neurontin, on the other hand, they call it, its other name is gabapentin, reduces excitatory neurochemistry. It doesn't actually work on GABA. It works on reducing norepinephrine, which then if you have a person with a fast alpha, as well as, standing alone with fast alpha or with spike and wave activity, Neurontin would be something you could consider. Now, Lyrica is just a relative of Neurontin. It's a pregabalin, and it's a step stronger than Neurontin is. Lyrica can actually be abused because it has certain properties that can become abusive. We don't see the use of Lyrica very often in psychiatry. Psychiatrists don't like medicines that were for, a lot of other things that are just physical ailments. So the challenging cases for neurofeedback clinicians, I want to go into first is autism spectrum disorder. And also, if you guys work with the autistic children like I do, I work with hundreds of autistic kids. They usually put them on a little bit of stimulants to start them out with for their ADHD symptoms, because most every autistic child can be diagnosed with ADHD. Then their anxiety, their OCD starts kicking up, and they'll hit them with an SSRI, which are designed symptomatically to address anxiety situations and OCD. And then as they progress into middle school, and the stressors of middle school are getting worse, and their behaviors at home are getting worse, and they start punching holes in the walls and start going into rage events, they'll hit them with an antipsychotic. So now you've got stimulants, SSRIs, and antipsychotic polypharmacy on this child's head. And a paper that I have listed in the back of this study that I'll send to Rob to post. 40% of them that I see, 36.7% actually, in my study that I did, had epileptiform activity. And stimulants, SSRIs, and antipsychotics worse. So the things that we're looking at is, what are these children on that you're going to be doing neurofeedback with? And what are we going to do to try to alleviate some of the problems that we're having to counter? And if they've got medicine on a child's brain that's going to make the seizure activity worse, it's a tough battle. You can't outrun medication and polypharmacy, especially with neurofeedback. Also, children with ADHD. Let's take the simple. I did love that paper I got this morning. Rob put me on your list, which I was really appreciative of. And it was a Science Daily study identifies distinct origins of ADHD children with history of brain injury. I've been preaching this for the longest time, that if you don't have ADHD, you get a brain injury, it'll make you ADHD. And if you've got ADHD, it'll make it worse. And that's what they're saying in this paper. So ADHD is not homogeneous, it's heterogeneous. And there's a lot of different causes of ADHD symptoms. Now, ADHD in children, they'll start out with an amphetamine, possibly. If they're real skinny, they might start them with a methylphenidate instead. If they got tics, they'll probably hit the methylphenidate rather than that. Once that fails, they'll go on and try Strattera. And if it's boys, most of the time, boys' behavior is more obnoxious than girls, and so they'll try them on the new Intunif, or not new anymore, but the beta blocker Intunif or clonidine. And so it's just a circle of what's going on as a guess to try to see what pattern that they have in order to be matched to the actual child. But symptomatically, you can't do it. We found in our study, the replication study, Millichamp was the name of this, the guy that did it in 2007. Millichamp and Millichamp out of the University of Chicago actually called him, got a hold of him personally, and asked for the exact details on the children that he studied. What was the age range? What was the gender mix? And I matched it exactly in our study. So we had apples to apples. But Millichamp and Millichamp, 2011, published, I think it was Clinical EEG and Neuroscience also. 32% of the ones we have that are referred into me, which I do admit, most people that I get referred for doing a Q on, they failed multiple attempts at medication. Well, 32% have epileptiform discharges that are ADHD. They may also have slow alpha. They may also have frontal midline theta. They may also have anterior hypercoherent alpha. But you don't want to treat any of that until you get spike stabilized, because once you got the lid on the pot, it's been our experience here that now you can come in with another medication that's matched to what's left, or you put the lid on the pot with the anticonvulsant, and neurofeedback will work like a charm, also will work wonderfully for the spikes. Challenging cases for neurofeedback clinicians continued, all with traumatic brain injury. I've got I used to do a lot of presentations, and I'm doing another one this fall in Dallas for a major rehab presentation. And one of the things that I show on my parents when a child has a brain injury, and these are the symptoms of brain injury: the prevalent cognitive deficits found in brain injury: poor attention, distractibility, impulsivity, poor multitasking, forgetfulness, confusion, slow processing. You know, all of these that we're listing here are definitely enough to classify somebody as ADHD. And guess what? If they've got a brain injury, they will not respond to medication, except if they've got spikes going on because of the scarring that occurs when the brain's attempting to reseal the blood-brain barrier and kill, in a process called apoptosis, and kill the cells right around these capillaries that are bruising in order to reseal the blood-brain barrier. Then you'll get spikes in a lot of brain injuries. If you have that, of course, you can use an anticonvulsant for the spikes. But the symptoms of brain injury, I put a whole another session together on brain injury and how it's affected by what goes on neurochemically with and organically with brain injuries over time. It's quite amusing. So there's a progression with brain injury too, and the top medications they use are stimulants, SSRIs, and antipsychotics also. True polypharmacy, and I do a lot of treatment of the military because I'm a Vietnam and a Desert Storm veteran, and I see a lot of military, and I tell you, the cocktail that these guys come in with it's really contributing to their doing very poorly. There's a high prevalence, and I looked this up yesterday, and almost 60% of the brain injured people we can find epileptiform discharges. That's pretty high prevalence rate. Summary: as long as we have mental health diagnosis based on symptoms, psychiatrists will continue to medicate based upon the diagnosis. Neurofeedback therapists will be challenged because of it. It is vital to have each EEG read by a board-certified electroencephalographer to identify epileptiform discharge and their foci, so we can treat the areas that are discharging. And I should have put in there and identify encephalopathy so we can get further testing, find out what's causing this low voltage slow EEG. Having the correct medication is one part. Having the correct protocols is the other. So if you do a qEEG and you got a person with a left posterior temporal spike around T5 or 1, T3, you don't find any focal slowing because it is isolated and transient because it's averaged out or whatever, and you miss this, you're going to be missing a vital one of the protocols that you need to do in order to make this brain better. Because as long as it's misfiring, information is not getting passed between parts of the brain that need to be communicating together. So that's why I would say we've got to identify the location of where these spikes are discharging. So that would be used to help design protocols. And last is those who do qEEGs are in the greatest place in the world to provide valuable data for psychiatrists. And the way I did it for psychiatry is I kept going back to Dr. Carnell, my doc, and I said, you know, you might want to know about these spike and wave activity because a lot of the medication that you use makes this activity worse. It took a few years, but finally, you know, he said, I'll try it. So we published a study. What happened when we put 76 people, this is how many we had records in our chart in our office, from inside the practice treated by Dr. Carnell. All of them had EEGs and qEEGs. All of them had spike and wave activity confirmed. And we put them on anticonvulsants. They had all failed multiple attempts at normal psychiatry, multiple attempts at medication. We're on multiple medications. We didn't look at age. We didn't look at diagnosis. We looked at nothing but had spikes, put them on an anticonvulsant. 85.5% of them improved. 6% of them stayed the same. And 6% or 7% actually got worse, and we just switched to anticonvulsants, and it did better. It had to do with the component I talked about last time, the gene site study, because their bodies weren't able to use the anticonvulsants when we dug a little deeper. They didn't have the enzymes to process the specific anticonvulsants, so we switched to another one. Okay, I'm now open for questions. I'm right on schedule, so I can take any questions you guys have.
Okay, we have to unmute everybody, so I'll just start. Prepare yourself for the cacophony that occurs once we do this.
All right. And while you're doing that, I'll start off with a question, Ron. So, what have you found any particular way to sort of work with psychiatrists, any way to approach them where they're a little more understanding of what we do and accepting of what we do and willing to look at, you know, qEEG and all that, and, you know, collaborate?
Well, I think the problems that we have is that they don't look at it as anything more than doing qEEGs. So we have no medical background in order to be even discussing it with them. They don't understand the studies that have been done on qEEGs, and for the most part, they can get medications right for 40–50% of them. But if you do a EEG, and you're doing an EEG anyway, if you have it read by an electroencephalographer and you have his report with you, and it identifies some of these abnormalities, that's a great thing to take with you. The other thing is, on my website, I do have a list of all my papers, and I'll be glad to send those to Rob and to Richard in order to have them on available for you. And taking those in with what you're talking about, especially on the epileptic form discharges and that, when you find it and it's verified, I think they'll find this when it's published in Medline, PubMed journals, and medical journals, not just in a PhD journals. They tend to listen to it. It gives them some foundation by which they can change medications, especially when you're talking about anticonvulsants, for instance.
Great. Well, we'll look forward to getting some of those papers, and that would be wonderful. All right. I think most people are unmuted. So, questions?
Yeah, we got everybody pretty much unmuted.
Okay, I have a quick question. Have you seen any correlation between the EEGs and the SPECT scans, like Dr. Amen does, how those two correlate?
Good question. I have actually seen several of Dr. Amen's patients after I saw him. Pretty pictures.
Yeah.
But they do miss finding the EEG from a person that had a pretty good sized subcortical tumor called by. Oh, wait a minute.
Got him.
Hey, Ron, can you hear me?
Yeah, I can hear you. Back to
Sorry.
this. I didn't want to talk over a ring because nobody would hear me anyway.
Here's my question.
Lost my train of thought. Where were we now?
Talking about SPECT scans and how they relate.
Yeah, the SPECT scan completely missed the tumor. Totally missed it. And it was a rhythmic, slow tumor in the delta range, left T50 primarily. We got in there. The tumor was benign, but we've been watching it to see what happens to it over time. So that was one thing that really made me kind of take interest in SPECT scans and say, you know, how could that SPECT scan miss something like that? That seems to be a very important thing. Now, the qEEG would have shown a left temporal lobe focal slowing, but that doesn't tell you there's a tumor down there. So that's what, so I've seen the SPECT scans not give as much, and I really wish Dr. Amen would do some publishing of his research, because, I mean, or do some research and publish it, because there hasn't been much publication, so we don't know what to do with the SPECT scan.
That's really surprising that he would. I'm sorry, that's really surprising that it would miss a tumor like that, because he prides himself on being able to see those kinds of things. It should show a complete hole in the SPECT scan, a hole of activity.
You would think.
You would think, yeah. That's
you would think,
surprising.
maybe because it was subcortical, not cortical. So, yeah.
Oh, okay. Interesting.
One of the questions that came up before on this was this CNS response out in California. Daniel Hoffman's group that does it, and they actually work with Suffin or Emory, and they were on the board, and they used to read and interpret and everything else for them. And the problem with that is you have to have them off of all their medications, which I don't, and for so many 7 half-lives, and then you have to provide them with the data, and they run it against an algorithm. And the problem with the algorithm is that it does not catch. They don't have anybody that's an electroencephalographer read them, so you miss the some of the important stuff that only can be seen in the raw data, not in the qEEG, for instance. And they actually came back because they couldn't identify beta spindles other than excessive beta, and they wanted to put somebody on beta spindles on a benzodiazepine, which is totally contraindicated. And I said, I don't have much faith. You cannot take the human element out of what we do in this Pharmaco-EEG. Next.
I had a question about board-certified EEG review. Can you say a little bit more about that? There's people in neurofeedback that you probably know have qEEG and then a D as in dog. I mean, does that qualify a person to give the kind of insight that you're talking about, or would we want to have a neurologist review the EQ?
Okay, excellent. Make a really good point about this. In order to read raw EEG legally and ethically, you must be a board-certified electroencephalographer. Neurologists can read EEGs, but they're not boardified to read EEGs. So they're like a doctor that's in your primary care physician reading your X-rays. You know, you want a radiologist, you want a specialist. Neurologists will not call so many of the subtle things that an electroencephalographer will call. Now, Rusty Turner, on the other hand, who's a neurologist and an epileptologist, and he's qEEG trained. Because he's had the additional board certification as an epileptologist, he's probably really close to electroencephalographer. Jonathan Walker, who was a neurologist, was also board certified in electroencephalography. So that's where you really get the nuance that you want, because most of the time people get an EEG from a neurologist, they're going to say within the normal variation of a person this age, but they're not going to call the spike and wave because it's not a seizure. Okay? So you're not going to get very much from a standard neurologist.
Okay. Do you have any general guidelines for those of us who are in neurofeedback, and I'm a licensed psychologist, and who are kind of bombarded by all the different services out there for interpreting your report? And for example, there's Applied Neuroscience has a report writing program. It generates a lengthy, but it's automated. It's a report. There's different services. It's hard to know where to send your data to get the definitive analysis so that you can then come up with a protocol. And in a complex case where you've got medications simultaneously there, it becomes that much more important.
I will have to say I have a bias, and it's a bias of about many years. I think Jay Gunkelman does the best. He's certified EEG tech, as well as being a scientist in this area. I like his reports better than anybody else. He don't do a report unless it has an electroencephalographer signing off on it and giving his report. And so Jay says something to me all the time. He says, you don't want to become a hospitalologist because the qEEG has a big red blob in a certain area. You got to have clinical correlation. But number one, you cannot. That's why I don't like neural guide maps. They don't give you segments. I like the HBI maps better because at least the HBI maps will give you segments of the most important findings, and they will actually kind of point you in a direction if you've got transient discharges or vertex sharp waves of sleep or something like that. They'll capture it for you. But if you don't see it in the raw, it doesn't exist, no matter what the Q says. So that's my bias in the area. The problem is Jay Gunkelman's getting ready to retire in 2019 in October, and he's going to be leaving a big hole because he does ERPs, he does all neural guide maps, he does BSI maps, and I don't know who we're going to get to replace him right now. We'll just have to see, but we're going to be losing a big asset back then. I can do the medications. That's what I've learned over the years, and I could probably do the qEEGs with HBI maps, but I don't feel confident to do anything else. And I'm not qEEG trained, or certified. So that's what I would say about that. I know that who's the guy in Arizona?
Yeah, Ron, I use this is Dick Gennardi. I use Jay as well, and I also use Rusty Turner, and he does an excellent job.
Yeah, Rusty. I'm trying to get Rusty to consider it. They're not published together on the paper, so I know.
Yeah, I know. Well. And I've been working with him as well for that same purpose.
Right.
Hey, Ron.
Yeah, thank you for answering that.
I think he's the only one. I think. Okay.
Ron, for those of us who want to interpret the raw EEG more, like you spent time in your first webinar, what's the best way to learn to interpret the raw EEG? I'm not trying to be a neurologist or epileptologist, but just know the waveforms better.
Well, gosh, you just take so many, you're doing so many, you come across all these idiosyncrasies, and I learn something every day with all the ones I do with Jay. Jay wrote a book, The Art of Artifacting. I think that is the biggest red herrings that you've got to be aware of, is that sometimes you think something's real and it's memory. It's not real. So it's but that would be probably the one source book that I know of would at least get you started. I challenge myself with every case because I if it's real blatant, I can call the spike and wave activity and verify with my roller. Beta spindles, very easy to do. If you guys wanted a an hour's course on looking at EEGs and the nuances of them and some of the things that are really come out in your face, all that kind of stuff. We could put a webinar together on just so you have a working knowledge of what you're seeing. It would be fine. You know, what I go through when I look at an EEG, look at the voltage first and eyes closed. And if I've got a low voltage recording, fast or slow, that makes a difference. You know, most people don't look at the voltage because it's basically adjusted by the maps. They're going to show you colors no matter what the voltage is. But yeah, if you guys want to put something, I could put something together and have a whole series of, you know, just the EEGs we can look at. And from again, I'm nothing like Jay Gunn. Jay Gunn will be the one, but he's going to talk over most people's heads. But he's the best there is out there.
Yeah, I agree. Thank you. That's helpful. The other thing, what kind of protocols are you using, say, for traumatic brain injury? Are you doing amplitude or Z-score training? What you doing?
Okay, now you're going to get me into some more of my biases.
Go ahead. Let her rip.
I use amplitude training exclusively because, and I've had this argument with Al Thatcher and about live Z-score and about coherence training and everything else. Coherence and malshared variance between 2 points. You can't do coherence training as it is right now because coherence cannot fix the good side and make it the reference while you're trying to make the other side and better. So you actually make one side worse, the other side better to meet somewhere in the middle. That's a problem with amplitude training. I mean, with live Z-score, any of that kind of stuff. Again, live Z-score is based upon an algorithm and not a person sitting there watching it. So if they would do the research, if anybody gets up there and does the research and publishes the research that compares side by side with amplitude training, it's better. I would probably make the switch over to some of that. But until they come and produce the research, the marketing advertisement and the marketing research doesn't impress me. So I'm staying away from it. In fact, even the low energy neurofeedback system and everything else that they've done there's no research in it. I'm a research-based scientist, so I got to have the research first.
Great. Thank you for sharing your biases.
Sorry, but at least I tell you I'm biased, you know?
Many of us here, Ron, are, you know, pretty much amplitude training folks. We're doing magnitude training, and that's, you know, what many of us do here. So lots of support there. Any other last-minute questions for Ron? We are approaching the top of the hour.
Yeah, here's a quick one. What do you do in the case of intermittent epileptiform activities? I have a feeling I have a client who has seizures, but maybe like once or twice a week, and it's not always going to show up on a qEEG, but I just get the sense that he has these absence seizures. Do they show up in general somehow?
Okay, the studies have found that people with known epilepsy on their first EEG, 53% of the time their EEGs will not show any isolated epileptiform discharges. That being said, if you want to sleep deprive a person, there's a high likelihood if they're there, they're going to show. That's your choice. Okay. I don't hyperventilate. Hyperventilation is one way to get an absence seizure to come out. I don't do that. I'm not gonna. I was a firefighter paramedic for 20 years. I don't want to treat more epileptic cases in my office for sure. So they, you know, what I would say is if we pick up isolated epileptiform discharges on one of our EEGs, that's a serious case because we're going to be missing it. Now, when you do series over time, like I've done with kids, start out at 6 and at 8 and 9, 10, and I've done 6 EEGs over 5 or 6 years. All of a sudden, when they hit puberty, guess what? That beautiful baby will spike and come out like crazy because now it's lower seizure threshold enough. We can see sharp activity that doesn't quite meet the level of epileptiform activity. But if you got sharp and slow wave and maybe not paroxysmal, sometimes they can be paroxysmal. But if you've got that, then you can, based upon the psychiatrist, based upon the presenting symptoms of rage events and everything else that would go along with these discharges, really neurological atypical symptoms, we have gone ahead, even though we didn't have frank spike and wave activity or big old paroxysms, put them on the medication, knowing that they may be a brain spike, wouldn't get to the surface as a spike, would only show up as a sharp, or that they're just not being caught or significant at the time enough for us to say, but we watch them over time. And those little transient discharges, sharp and slow activity that aren't epileptic form yet, then will actually grow and become so over time. Again, the sleep deprivation is probably the best way for you to try to get a good reading if you suspect something like that. And if it comes out as you sleep deprive them, and you get an electroencephalogram to call it, you're in good shape.
Okay, well, we're about out of time, folks. We're just past the hour. A lot of you have clients, and some of you are already heading out. So thanks very much, Ron. It was a great presentation. Rob, you have anything?
Thank you much, Ron.
I don't think anybody's ever got that before. So
if you can send us out your PowerPoint, I'll distribute that to those that attended. That'd be lovely.
Thank you very much.
And thank you much for attending, Ron. Really appreciate your workshop, your time with us these two past sessions, and thanks so much again.
Right, it's a very relevant topic. Thank you.
All right, no problem.
Bye, everybody.